Good morning, everybody.
Morning.
A couple minutes to get assembled, and then we'll try to get started as close to 11:30 as humanly possible. Oh no, Kim made it on time. I was actually looking forward to her showing
Sure
up.
did, Chad. I sure did.
That's a downer. I thought we had some POVIC free time, but it's all downhill from here, everybody.
I'm happy to jump off, Chad. If you have this, I'm happy, more than happy.
I'm not sure how that affects good or bad, what's getting ready to happen at 11:30.
If I leave, you don't have an agenda, Chad, so you want me here.
We know about how many people we're expecting. That's the one thing I haven't really looked at.
I think somewhere between 30 and 40, Chad.
Yeah, it's a pretty good list. Okay.
Yeah. Mm-hmm.
We're still
Yeah,
listing
that's
right now.
correct. Okay,
Okay.
thanks, Jen.
We'll wait till 11:31 and then we're gonna go. If people don't show up till 11:32, they miss the first minute when we give out the secret raffle prize.
Are you paying for it?
Oh no, I was just gonna raffle off where it is.
What were you gonna raffle off?
Whatever it is that's hanging behind your head on the wall.
Oh,
Oh, well, that would look good at my house.
okay. Yeah, Kathy, I'm happy. I'm happy to get it to you. It used to be in one of my old offices, and then it ended up here. So
Oh, so you steal from your employer. That's what you're trying to say.
Yeah, wasn't
No,
that an
hey.
AHP thing?
no, I paid for that.
That was the original AHP logo that Kim
That's
stole.
right. Wow. Wow, that's kind of awkward to get the call started with
Yeah, this is weird, huh?
employee theft.
This is recorded. John, can we edit this?
That'll be good for evidence in court.
That's right.
Jen will not be destroying evidence, right, Jen?
No problem. So just to note, I just got a chat. Sue Kinney is under the name
Christine
Chris.
Walker.
I'm under another name because I didn't know, I can't sign in under.
Oh, that's right.
Okay, so I'm here, but under a different name.
So Sue, if you click the little three buttons in the upper right-hand corner of your little box, you can rename yourself.
Oh, wait a minute. Oh, right here?
Yeah.
If it's that important to you.
And what, oh, rename. Oh,
Yeah.
thank you. You know,
You're
I'm not the
welcome.
techie person.
All right, so it's 11:31. Should we roll?
We shall. And before we dive in, because we have the care management teams with us today, I just want to say a sincere thank you for all of you who worked countless vaccine clinics. You all really, it's nurses who have vaccinated our community, and you all stepped up to the plate big time, not only on your team days, but several of you have just kept coming back, and it is so appreciative. So appreciative. So thank you, and thank you. Today, we're here to kick off our osteoarthritis initiative and tell you a little bit about the background, walk through some high-level workflows with you all, and have some time for you to answer questions. So Chad's going to start us off with some history about how we even stumbled upon this opportunity and the relationship with orthopedics. I will walk through, again, just some very high-level workflows. Mark is with us today, and Mark has a few words he wants to share with us, HP's COO. And then we really want to open it up to all of you for questions and have a discussion about anything that might be helpful to you all. Does that sound like a decent agenda for the day?
A lot of nods.
Awesome. Chad, turn it over to you.
All right, thank you very much. So thanks, everybody. Thanks for taking the time to join in. This is now going to be the third large-scale, we call IPCs, but clinical initiatives that we will be rolling out through AHP. And this one has yet another new foray into IPCville of kind of new frontier for us. So we're pretty excited about this. So I will say the genesis of this one really has multiple different starts. So number one, from time immemorial, one of the big asks from primary care physicians, even some of the care managers, is we're a large network. We have all the different subspecialties. The spend is predominantly not in primary care when we talk about modern healthcare. So when are we going to start focusing less on primary care and more on the specialties as far as a way to generate engagement and generate savings? And truthfully, we've had some success in prescribing initiatives. We've made a few forays into partnerships like around colorectal cancer screening and the like. But generally, these were specialty input into primary care workflows. So this will be the first effort that will live predominantly in the specialty space, and hopefully will be a springboard to further engagement of our specialists across the AHP network. Number two, and perhaps more importantly, as all of our IPCs, we always start by identifying either variations in cost of care or variations in care delivery across the network. And what we found looking at reports that were predominantly coming from Excellus, and this really goes back now probably almost 3 years ago, when we looked at big service line costs, what we found is one where we were notoriously cheaper when we provided the care in network with one of our providers was large joint replacement. And quarter over quarter, year over year, it was one of the few where we were notoriously cheaper than when our patients would go out of network and get a joint replaced by a non-AHP provider. At the same time, we started to look at kind of leakage and where were opportunities to support our hospital systems by keeping care in-house. And joint replacement, as can be witnessed by anyone who's driven past Marketplace Mall in Rochester, is a big revenue stream for the university. And yet 30% of our joint replacements go out of network, not with an AHP provider every year. And when they do go out of network, it's about $4,000 more expensive just for the surgical care than if that care were provided in network. So both there's an opportunity to support our hospitals, but there's also an opportunity to provide that care cheaper by doing it in network, which then generates gain share. Going to the next level, the question was, why is this 30% going out of network? Is it because the quality is better on the other side of the fence? And come to find out that was not true. So when we looked, not only is it cheaper, but patients who get operated on in network are less likely to go to rehab post-op. They are less likely to get readmitted post-op, and they are less likely to be reoperated on in the next 5 years than if they are done out of network. So now we actually had the genesis of what we kind of now refer to as one of our unicorn initiatives. It's cheaper if it's done in network, so there's a value-based savings opportunity. It is driving fee-for-service revenue for our hospital members to keep that care here rather than sending the fee-for-service dollars elsewhere. And it's providing better quality for the patients that we serve. So that's a win-win on all fronts. Normally, you have to give up one of those whenever you do these initiatives, but this one really touched the bases and was a win on all three. So when we looked a little further, what we heard loud and clear from primary care docs is it's just not easy to get the patient in network. So either the U of R is booking out months into the future, whereas Unity can get the patient in within the next couple of weeks, or when we send the patient to the U of R, They want their A1C optimized. They want their weight under control. They want them to go through a course of physical therapy, all of which, by the way, are actually evidence-based and appropriate. But for the patient who has reached the end of their line and is in agony because of their arthritic pain, they're not willing to wait another couple of months to either see a doc or jump through another several hoops before they can be a candidate when the guy across town will do their operation in the next 2 to 3 weeks. So then we came up with the discussion, okay, we need to find a way to get these patients in more efficiently, because we know if we can get them in our system, we'll take better care of them, but we need to kind of provide that longitudinal care. And the other thing we heard from primary care physicians is, we don't want to send them to you and you guys tell us they're not a candidate for surgery, send them back when they are. We're actually looking for you, orthopedic surgery, to tell us what the right care is. So we spent quite a while, I will say months really, with the orthopedics team, both to try to define what is wasteful care that's not adding any value, and what is good longitudinal care that if you could get a hold of these patients sooner, you would be able to optimize their care, enhance their outcomes, and maybe even decrease some of them getting joints replaced at all. But in exchange, you'll get a larger flux of patients who are going out of network. So your total surgical volume will at least be equal, if not higher, but we'll have a larger crop of patients that are getting good evidence-based care. And basically what they have now generated is this non-operative pathway. So they have sports medicine trained providers, many of whom their background is in family medicine, some are internists, but they did orthopedics and or sports medicine fellowships, but they focus on the non-operative care, which you say, well, in orthopedics, isn't non-operative care just like NSAIDs? Well, there's joint injections, there are nerve ablations, there are hyaluronic acid injections. Even when we look across our network, and you guys have probably heard me talk about this before, every quarter we have 1 or 2 patients who gets Duexis, which is ibuprofen and famotidine, each of which costs about $5 a month if we just provide them the prescription individually. But if you give them the combo drug that's under a brand name, it's $1,200 a month for the patient to get that combo. There is no enhanced care for the patient. It's the exact same drug that they can get off the shelf at Wegmans, but because some PCP, who I have to believe is not trying to undermine our value-based contracts, decides to write that prescription a couple times a year, we wind up footing a bill for $1,200 a month for a drug that should cost a couple bucks. So again, there's that opportunity for better education and cross communication between our specialist colleagues and our primary care delivery teams. So this non-operative pathway really is meant to get patients in sooner, earlier in the course of their large joint osteoarthritis history, with the goal of providing some of those preventive measures. So getting them an adequate course of physical therapy, getting them on appropriate evidence-based non-steroidals, considering who would benefit and who would not benefit from joint injections, and then ultimately charting a course to say, if A, B, and C fail, they would need joint replacement likely within the next 6 to 12 months. But here are the 2 things that they would have to do to become a joint replacement candidate. Their A1C is going to be under 9, and they're going to need to lose about 20 pounds before that point. It's a lot easier to hear that a year from now, I need to lose 20 pounds, than it is, I need my joint replaced today, but I got to lose 20 pounds before they'll do it for me, because that sends patients scurrying. So our thought is, if we get them in the continuum sooner, we'll both provide that longitudinal care to where it's a trajectory, not an endpoint, with the hope that we can actually steer patients away from joint replacement. But if not, we will provide that kind of ongoing continuity so both the patients and the primary care team know what are the landmarks that will both tell us that they're nearing joint replacement, but what are the things they're going to have to do to be a candidate when that day comes. To try, and Kim will talk about this more in a second, to try to further that, we've identified a group of patients who have had at least 3 visits in the last calendar year for large joint osteoarthritis. Primary diagnosis was osteoarthritis, but they have not seen an orthopedic surgeon over the course of the last year. The thought being that this is becoming a bigger impediment in their daily function because they had that 3 or more visits. but they're not getting that specialty care at this point. The hope will be that that will jumpstart this process, while at the same time, we want organically for you and or your provider partners to refer anybody without criteria. It could be the first time you've ever seen someone for large joint osteoarthritis. And if you think that their care would be enhanced by being referred into this non-operative pathway, there is no hurdle they have to jump over to be referred in. The care team and the orthopedic surgical group will then, they have a templated note. So all of these consults will look very similar. They have a list of recommendations that those will be tailored to the individual patient. But we also wanted to make sure that this was not going to be the orthopedic surgeons just following patients forever and adding cost of care in that regards. They will set up a care plan that they will then share back to you and your primary care teams, with the understanding that if there are points of failure, that they are exiting that care plan, the orthopedic team can get re-involved at any point. So it will not be oh, we'll just see this guy every month and just keep billing them. It'll be, here's what needs to come next. If this doesn't work, call us and we'll get them back in. They're going to both try to make this more expedited so that they get these patients in a timely manner, but also plan to maintain that longitudinal engagement, so that if you reach out and say, okay, the plan that you put together in March is no longer working, they can get them back in and push them along that continuum as appropriate for that individual patient. The anticipation of this program is that there could be about 3, maybe as much as 4.5 million of savings that we incur as a network by getting this care done in-house and potentially decreasing the number of patients that actually go on to joint replacement. But when you look at the direct fee-for-service revenue for the hospitals, total, we're looking at about a $7 million enhancement in either fee-for-service revenue for our hospital partners or in gain share revenue that would be due back to AHP. So this is a big one as we look forward as far as potential savings that we think we can start to make some big chunks in our cost of care and care delivery. So that's really the backbone of why this came to being and what we're trying to accomplish. And now I'll shut up.
Thank you, Shad. We'll dive into just some high-level workflows. I do recognize AHP and PCN will have slightly different workflows, so Danielle and Karen will be talking to you more about the specific details of them. But hypothetically, right now, we're working with Excelis to get a list of patients who meet the criteria that Chad mentioned earlier, patients who have had 3 or more visits with their primary care physician with a primary diagnosis of large joint osteoarthritis. They will be sending that to us in an Excel spreadsheet. And as I mentioned, the workflows will be a bit different for PCN and AHP. However, this information will be shared with you through that mechanism, through an Excel spreadsheet. The idea there is then that you would take this list of patients and talk to the physicians in your practice about them to gauge their, to get their how do I want to say it? Their take on the patient's needs and if this would be an appropriate referral to this non-operative pathway. When we've looked at the lists, we had an opportunity to pull up Karen's old practice, Lori's practice, Danielle's practice, and honestly, there's anywhere from 3 to 8 patients per care manager is what it looks like right now. Some of the larger practices will obviously have more, but it seemed like a pretty manageable workload when we were able to pull up those patients just to gauge the volume on this. So once those conversations happen with the physicians, Orthopedics has created a referral sheet just for this initiative that your practices will fill out and refer a patient just like they would any other subspecialist. So that referral burden will not be on you, but it will be on the practice and the typical referral workflows that already exist in those environments. The orthopedics team have created a specific template for this initiative, and that's how we'll track the data and the outcome. So we're currently in the process of creating an analytics plan. And I think we're about 75% done with it. We're just dotting I's, crossing T's, but we'll be able to key off that template to look at the number of AHP patients who have been referred to the program and track them over time. Most of the cost savings of this program will occur over the next 2 to 5 years. So we're looking forward to collecting those data points along the way. that's really the high level workflow, the analytics plan. I'm going to defer to Karen and Danielle to dive into the details of those workflows with their respective teams. I want to make sure we have time for questions at the end. And Mark, I'm going to turn this over to you just to share a few words, and then we'll dive into questions.
Yeah, thanks, Kim. And I think those questions and feedback will be really interesting to hear. So I'll only take a minute, and largely just to, kind of underscore a couple things both Chad and Kim have said. I was interested in attending the kickoff today, and there was an earlier kickoff with the physicians that I missed, unfortunately. So I really just wanted to sit today. And, I think this is a big deal. We're really excited to move forward with this. I think, you're all aware of several IPCs that we've got going, and obviously your roles in it. And this is one that we first conceived of, I don't even remember, 18 months ago or longer. And, as Chad was saying, the orthopedics department, we've really partnered with them well, and they're really excited about it. The U of R employee health plan, and remember, AHP contracts with the U of R employee contract, which health plan, which all of us as employees know that, actually is very excited about this. And this is one of the things we're responsible to deliver is the successful execution of this. So we're excited to move it forward. And I think Kim has gone over the specifics quickly, but well. We think there's a couple of important paths of how we can identify patients who are eligible here. And obviously the physicians are a big part of that, but our care management team has a role here too, which I know we'll go into more detail on, but we're hoping that it's a modest lift, because we know there's a lot of other things going on. But I just wanted to underscore my excitement for this moving forward, because this is one of our big initiatives for 2021, and really appreciate all the work that this team will do as well. So that's all I'd really add, Kim.
Thanks, Mark. We appreciate
Sure.
that. And we share Mark's excitement. You're probably wondering, when are we starting this? We'll start August 1st. Lists will come out no more than quarterly. We're not anticipating this is going to be something that happens on a yearly basis. Part of where we are right now is we're kind of digging ourselves out of the hole. In essence, there's a group of patients that we need to catch up on. And our hope is truly that the primary care physicians, this will just become part of their day-to-day work, and really utilizing and leveraging you all and care management in the practices to help us bridge that gap until primary care physicians are seeing these patients regularly and can identify them, which will make these lists obsolete. So again, we anticipate this going for about the first year, getting lists quarterly, and then after that, it really dying down. So just really want to open it up for questions, comments, feedback, concerns.
All right, perfect. It went great. That was great. Then we're all good. It's the only pair participating. Do you want to take that, or you want me to?
You can.
Okay. So we heard loud and clear from the primary care physicians that for this to be successful, it has to be payer agnostic. So while the data and the genesis of this comes from Excelis data, and those patient lists that we will be sharing largely emanates from Excelis data sources, because that's the largest chunk of our contracts, the anticipation is that this will be completely payer agnostic. So if your providers have an MVP, a Medicaid, whatever, orthopedics could care less who the payer is. And in fact, it's to the benefit of them if they have more patients in this pathway, regardless of payer at the end of the day. And Excelis is not even the best paying payer that they have for their joint replacements. So from your standpoint, we will be kind of egging this on from Excelis-based data, because that's what we have most ready access to. But to Kim's point, that's really just to kind of whet the appetite of the primary care teams to get them used to using this service and to seeing the value in it. If this goes well, ultimately it will be completely organic. And when the providers in the room, they will make this referral spontaneously on their own. They'll need to be only a very shallow involvement from the care management and the AHP team, other than on the back end from AHP side, tracking the utilization of that template and what the ultimate outcomes are for those patients, so that we can provide back to the primary care teams and to all of you, what's the savings, what's the improved outcome for patients. And ultimately, we'd like to be able to get to a point where we can actually talk about what the patient outcome and experience is like, because one of the nice things is orthopedics is very enmeshed in Promise, which is a patient-reported outcome system. So that is a foray that will be of potential value to us as well. As you know, not we know what the medical outcomes will be, but we don't always know what the patient's experience is like. And that may be an avenue of this program that will be a tangible gain that was not part of the original intent.
I have a question about workflow wise. Once we have that discussion with the PCP and we're communicating with our staff to get the referral faxed over, is anyone communicating with the patient? Is the practice or the care manager calling the patient to say, hey, we're doing this, expect a call from ortho? Or does ortho educate them at all when they get that referral?
Question. So I will say what we've heard so far, because we've posed several different protocols of how we may do this to the primary care docs, and both from the community and PCN, pretty resoundingly, we heard that, I will say, the primary care team, not necessarily care manager, but either the doc and or the practice team, they felt it was important that they make the introduction to orthopedics rather than orthopedics being the first line of reach out. Truthfully, orthopedics almost preferred just send me that list and we'll just start calling these people and getting them in. But the primary care docs both wanted to be the gateway to determine, do I think this is the appropriate patient who would do well in this program, but then also to make that introduction. And I'm more than willing to concede, I think that's good care. So the anticipation is not necessarily that it will be you all that are doing that outreach, but rather, as part of the primary care team in your offices, if the doc wants to make that introduction, if it's someone else in that practice, I leave that to the individual practices to decide. We're not going to mandate they have to do it a particular way. We are interested in hearing back about which of those patients get referred. And truthfully, the reason we want to hear back is we want to see what the value of these, I'll call them chase lists, are. If there is no return on value, or if you guys say, you know what, the providers are already aware of all these people, so they didn't find any value in getting this list, then there's no reason continuing this for the future. So it's both to see, is this longitudinally of benefit? And then of those who we identify, which ones did the providers feel like were good candidates, and can we differentiate what made a better candidate than not? So that for the future, we can determine, should we enhance the list or do away with it completely?
Chad, I've been getting some questions in the chat that I just want to address. The template, there's two things. The orthopedics team is using a documentation template in Epic. However, the referral form will be a physical paper copy. Orthopedics has sent it to the print store, and those will be getting delivered to all of the primary care offices in AHP to make that referral. I do not believe referrals will be happening via Epic. I believe we are going with this paper version until something can be added to Epic, but both will be viable ways to refer. The reason being, it's taking a bit longer. It's a new build in Epic, I guess, so it would take some time to actually get that in there up and running. The lists are coming straight from Excelis. Recognizing that we have patients in 11 different EMRs, we needed one central source to pull these data points from. So the patient list will be coming from Excelis.
Other questions that folks have? Either in chat or live, however you prefer. So I will say, to Kim's point, there's several logistics issues here. So one, the initial list that we'll be sending out is relatively small. That's both a blessing and a curse. So number one, you'd like to have a big throughput of patients so we can get a good sense right out of the gate of how this is working. It probably won't be a gush of information that we have on this right away. Number two, to Mark's earlier point about the UR health plan, because we are contractually obligated to deliver on that this year, we're going to be most attentive in the first phases to trying to get the UR health plan patients through. And in fact, I would even say both because we want to use them as a test case, but also because we want to make sure that we're dancing to the tune of our contract. And the providers know this. We almost want to say there should be a referral except by exclusion for those patients, because we think that this is going to be good for everybody, but we might as well learn from it when we're also getting contractually obligated to meet that mark at the same time. So that list is even smaller still, that for the UR health plan members that will be part of this, and we'll be able to identify those people to you when we provide that list to you, so it won't be a guessing game. But I think we're going to see some trickle from the faucet. I think that organic, the provider experience, willingness to refer in. There'll be some who will probably refer 5 people in the first week. There will be some who won't refer 5 people in the next year. So because of that, each practice's experience will probably be a little bit different. But I would say, because you guys are the eyes and ears in your individual practices, if you are hearing feedback, good or bad, about the referral experience, about the care plans that are provided back to the providers, we want to hear those things. I mean, obviously, we have asked the providers to reach out to us directly, good or bad, but oftentimes that doesn't happen. So, I realize oftentimes what you guys hear is not always the good stuff. Oftentimes it's just the bad stuff of these things. That's okay. But if there is a problem and we can't answer it or address it or prove it wrong by the analytics, then we're very committed, as is orthopedics, to amending this program going forward. But because there will be that trickle effect, I want to reassure, but also caution, that we're not going to have enough data to, unlike readmissions where there's 1,200 patients being discharged a month, there's only 1,200 patients who this applied to all of last year within AHP. So it's not going to be that gush of information analytic flow that we've seen from some of the other initiatives.
And just a few other points before we wrap up today. The analytics, once we get some initial data, we will share that with Elisa, Karen, and Danielle, and let them be the mechanism through which you receive those data points. Initially, it'll just be volume data early on. We won't have utilization and cost data probably for a few years, just because of the time horizon for making an impact here. And then lastly, Kevin Kelly is our project manager. He joined Chad and I a few weeks ago, I think 6 weeks. He's been at AHP for about 1.5 years already and came over to support us. You probably recognize his name. He helped us out quite a bit with post-acute care, and he's also assisting with osteoarthritis. So you will be hearing from Kevin probably more than you'll be hearing from Chad and I. But if you have questions about any of the logistics or the specifics, please feel free to reach out to Kevin directly. He's currently on vacation, enjoying some time away. And that's all we have. Any other questions we can answer before we wrap up? Okay, well, once again, a sincere thank you. We really appreciate your partnership on this, and we know this wouldn't happen without you. So we really appreciate it, and we look forward to sharing in the success of it with you all.
Well said, Kim. Thank you, everybody.
Thank you.